Our next lecture is on cerebrovascular disease. And just as a reminder, we've started peripherally with muscle, and now we're working up to, have worked our way all the way up to a number of different cortical diseases and pathology. And so we're talking about cerebrovascular disease here. Now, we have previously covered other stroke syndromes. For example, when we went through brainstem and cerebellum, we talked about strokes there. We've been through the small vessel stroke syndromes in our subcortical section. And so this will be going through cortical strokes and also how to distinguish them from the hypertensive hemorrhages. That will be kind of the main goal here. And so I won't review the detailed anatomy, cerebrovascular anatomy, but it would be important that you're able to go through and identify all the aspects of the posterior circulation from vertebral arteries and pica, basilar artery, and then the internal carotid artery with the middle cerebral artery, the anterior cerebral artery. But we've done that in more detail previously. And if you need to, you can pause the video and stop and just remind yourself of all of the branches here off the circle of Willis. But it really would be good as a review just to test yourself to see on a blank sheet of paper, can you draw it out and can you imagine what would be the clinical deficits from occlusion of each blood vessel along the way. Right, so remember that the carotid artery here has four different, anatomically, four different portions here, the cervical, petrous, cavernous, and supraclinoid, and this is the portion here that gives off our intracranial blood vessels. So here's the middle cerebral artery and the anterior cerebral artery off the supraclinoid portion. And of course we have the paired vertebral arteries that travel up and together form the basilar artery and the posterior circulation. It's important to remember the homunculus, so the motor and sensory strip here, that the face has a very large representation here laterally in the precentral gyrus, and then the arm and the hand especially has a very large representation. The leg fibers are medial, and so the motor and sensory strip here really parallel each other, but this will be important when we think about especially middle cerebral artery strokes versus anterior cerebral artery strokes. So recall that the middle cerebral artery supplies most of the lateral surface of the brain. The anterior cerebral artery supplies this upper portion, the superior frontal gyrus, and most of the medial portion of the brain. And the posterior cerebral artery supplies the undersurface of the temporal lobe and the occipital lobe, which we can see here on this sagittal section. So let's start with middle cerebral artery stroke, certainly the most common cortical stroke. And so what's in common for whether it's a right or left middle cerebral artery stroke is that the patient can have contralateral hemiparesis and sensory loss. So remember, if it's a more lateral, peripheral occlusion of the middle cerebral artery, it's going to be more arm and face, less involving the leg. The optic radiations are supplied by the middle cerebral artery, and so patients may have a contralateral homonymous hemianopsia, or if it involves more the temporal or parietal lobe, we'll get either an upper or a lower quadrantenopsia. Remember that if it's temporal lobe, it's going to be a little smaller, pie in the sky. If it's parietal lobe, it'll be a little larger than a quadrant. And then if the frontal eye fields are involved, the patient may have a gaze preference. So we will see these three things, whether it's a right or left middle cerebral artery stroke. So again, here's the motor and sensory strip, the frontal eye fields here giving us a gaze preference, and here are the optic radiations here, the dashed line, which will give a patient a contralateral visual field deficit. All right, so if a patient has a complete massive middle cerebral artery stroke, they will have all three of these things, the motor and sensory deficits, gaze preference, and the contralateral visual field deficit. But of course, most middle cerebral artery strokes, it's going to affect only a portion of the vascular territory, so patients may not have all of that. And so again, if the occlusion is more out here peripherally along the middle cerebral artery, then it's going to be mainly the contralateral lower face and the arm. If the occlusion is more proximal, then you're also going to get the penetrating branches here, these lenticulostriate branches that supply the internal capsule, and then you'll have a pretty dense face, arm, and leg involvement. Now, if it's the language dominant hemisphere, which is usually the left hemisphere, certainly in a right-handed individual, and even in a left-handed individual, they're more likely language dominant in the left hemisphere, then we will have an aphasia. So if it's more posterior, we'll have a Wernicke's aphasia, and so this is a fluent aphasia, but they don't understand. And the optic radiations are immediately adjacent to Wernicke's area, so these patients usually have a contralateral homonymous hemianopia, or we can say hemianopsia. If the stroke is more anterior, affecting the inferior frontal gyrus, then the patient will have an expressive aphasia or a Broca's aphasia. And since the motor strip is immediately adjacent to that, these patients usually have a contralateral hemiplegia. Okay, if we affect the connection between Wernicke's and Broca's area, we'll have a conduction aphasia where patients can't repeat sentences. And if we have a large MCA stroke, we'll have a global aphasia. And so let's just kind of go through the common one first. So of course, if we have a massive global aphasia, it affects Broca's, so they're not fluent. It affects Wernicke's, so they can't comprehend, and they can't repeat. So that's a large MCA stroke. If it's Broca's, then it's not fluent, so getting words out is very effortful. But if Wernicke's area is intact, they can understand and they can follow commands, but they're very poor at repeating sentences. So again, the location there is the inferior frontal gyrus. Now, watershed strokes can either be more around the Broca's area or around the Wernicke's area. And so if we have a watershed stroke that is sort of surrounding Broca's area, so Broca's area is still intact, but all of the areas around Broca's that allows Broca's area to communicate with other areas of the brain is affected, we call that a transcortical motor stroke. And it looks really just like a Broca's aphasia, but since the internal connection between Wernicke's and Broca's area is intact, these patients do much better repeating sentences. So that's the only difference. A Wernicke's aphasia, so again, just when you have someone with aphasia, are lots of words coming out, or is it very effortful to get words out? And so in a Wernicke's aphasia, it's fluent. Lots of words are coming out. So that's often the key initial thing that helps you decide, is it more an anterior or a posterior stroke? Okay, but they can't understand, and they're fluent, but yet they do make a lot of paraphasic errors, like the grass is greel or the grass is blue. Both of those would be paraphasic errors. And they're also, just like with the Broca's, they're very poor at repeating sentences, and so the location is on the posterior portion of the superior temporal gyrus. Now, if we have a watershed stroke that affects the area around Wernicke's area, again, it looks just like a Wernicke's aphasia. So they're fluent, but they don't understand, and they can repeat sentences. How can someone who doesn't understand repeat a sentence? Well, what they may do is, you're asking them to do certain things, they may just echo back words that you say, and that's often how we can detect that they have some intact repetition. Now, if we have a really large watershed stroke that affects both transcortical motor and transcortical sensory areas. Okay, so this looks like a global aphasia. They're not fluent, they can't comprehend, but again, they may echo some words back, so they can have some intact repetition. And a conduction aphasia, really rare, but this is a small stroke affecting the arcuate fasciculus. Patients come in kind of with some vague language difficulty, and the main difficulty on exam these patients have is they're very poor at repeating sentences, because that recalls understanding the command to repeat in Wernicke's, but then moving it forward to Broca's area, which they can't do very well. Now, on the dominant hemisphere, if we have a stroke further back, so here's the posterior superior portion of the superior temporal gyrus, and as we follow the Sylvian fissure back here, the area around it is the supramarginal gyrus. The angular gyrus is back here. And so if we have a stroke on the dominant hemisphere just posterior to Wernicke's involving the angular gyrus, then we can get Gerstmann syndrome. And this is a very interesting stroke syndrome. Patients mix up right and left, and they have finger agnosia. They can't identify their fingers. So good screening test for this is just ask a patient, hold up your index finger on your left hand. So that's very hard because they can't identify their fingers and they mix up left and right. So they might hold up their thumb on their left hand or something like that. This also is an important area of the brain for the ability to perform math calculations. And so give them a simple, what's 18 plus 14, something like that, they would do very poorly. And their agraphia is quite pronounced. So they do just very poorly drawing a clock or a cube, something like that. So again, you want to associate that with angular gyrus, and students get this mixed up all the time. This is the language dominant hemisphere, but they don't have an aphasia because the lesion is just a little bit behind Wernicke's area. Now, if we have a non-dominant hemisphere stroke, and so this, again, looks just like a middle cerebral artery stroke. They have contralateral hemiplegia and all of that. But the parietal lobe lesion here gives these unique findings. Anosognosia is denial of illness. So these patients come in with left hemiplegia, and you ask them what brought you to the hospital, and they aren't aware that they can't move the left side of their body. They have asomatosognosia, so that if you were to hold up, let's say, their left arm and hand right in front of their eyes and ask them, whose hand is that? They will say, it's your hand, doctor. And so the denial of the involved body parts are involved. They'll have a contralateral hemispatial neglect, and this is seen by asking them to draw things. And what you will notice is there are lots of details here on the right side of space, but on the left, in this case, nothing. So, or sometimes there'll just be just a little bit. And so that would be the contralateral hemispatial neglect. Extinction is an exam finding where you might touch the patient, in their arms and legs, and they can feel, they could tell if you're touching their left arm or leg, but when you touch them simultaneously, let's say on their right arm and their left leg, they will only say that they felt the right arm. So that would be extinction. So you need to be able to recognize a middle cerebral artery stroke. Here's a very large one here, sparing the anterior cerebral artery distribution and the posterior cerebral artery. You can see there's a lot of swelling here with the left lateral ventricle obliterated, and we have some cingulate gyrus herniation here. Okay, this is a more consolidated left middle cerebral artery stroke. Okay, and here's a right middle cerebral artery stroke, and if we do an MR angiogram, we can see pretty good flow in the left middle cerebral artery, but not in the right middle cerebral artery. Also get a nice look at the top of the basilar and the posterior cerebral arteries here. Now, an anterior cerebral artery stroke, since it involves the midline and the paracentral lobule, now the weakness and sensory loss is mainly in the leg, much more than the arm. Okay, so it's motor and sensory loss in the leg, and they also have urinary incontinence because bowel and bladder function is mediated here by this area. And so these patients can often be, they come in with leg weakness, numbness, some urinary incontinence, and they may be felt to have a pinched nerve in the back or something spinal cord. So we need to remember anterior cerebral artery stroke in an acute case of leg weakness. Now, typically, this occurs if we have a bilateral ACA stroke, or now we have some cognitive effects. So kind of a flattening of affect. That's called abulia. Their words have very little emotional fluctuation, very flat, for example. And they don't respond much. They're not very spontaneous. They're not animated. And they may also have some frontal lobe release signs, the grasp or glabellar reflex, and so on. Okay, so are the internal carotid arteries here, and here are the anterior cerebral arteries. This is called the A1 portion of the anterior cerebral artery. And remember, there is an anterior communicating artery right here. And so what we'll often see is that we might have an occluded carotid or an occlusion of the A1 segment of the anterior cerebral artery. But if the other carotid artery is patent, then it can maintain flow to both anterior cerebral arteries here, which go up along the midline. And so that's why it's not uncommon to see a bilateral anterior cerebral artery stroke. So the patient has an occlusion here. Well, now when they finally have a problem over here, now it's going to affect both anterior cerebral arteries. And here we can see both of them here coursing around the genu of the corpus callosum, coming back here to supply the paracentral lobule. So here is a patient with a bilateral anterior cerebral artery stroke. And again, these are going to have really a paraplegia, but also with some of the cognitive abulia effects. Now, just as a reminder, amaurosis fugax is a TIA where patients have painless visual loss that is sort of like a curtain pulled down over one eye or a mist that covers one eye for a few minutes and then it resolves. And so this almost always indicates emboli, retinal emboli from the carotid arteries, so we need to do a carotid ultrasound. And so these patients would certainly be at risk for having a middle cerebral artery or an anterior cerebral artery stroke. So it's very important we make that diagnosis, and if they have a significant stenosis of the carotid artery, then we would refer that patient for a carotid endarterectomy, in addition to doing other things to lower their stroke risk profile. Now in the posterior circulation, we have the posterior cerebral artery, which affects the occipital lobe. So patients have a contralateral homonymous hemianopsia, and the classic thing that should always jump out on a board exam is macular sparing. If they have macular sparing, it's a PCA stroke. And remember, the mechanism here is that your macular fibers have a dual blood supply, MCA and PCA. So if we have a PCA stroke back in the occipital lobe, the MCA still preserves flow to the macular fibers. We don't see this with an MCA stroke, because there the MCA supplies all of the optic radiations, including all of the macular fibers, through the optic radiations. So we don't get macular sparing with a middle cerebral artery stroke. Since the posterior cerebral artery supplies the undersurface of the temporal lobe, we'll have some cognitive changes, usually relatively mild, but no other focal symptoms. So you might think, well, we've got a visual field, homonymous hemianopsia, maybe it's an MCA stroke, but they don't have all of the other things that we just associated with a middle cerebral artery stroke. Now remember, we've talked about before, if you have a very proximal occlusion of the posterior cerebral artery, you may get Weber's syndrome with ipsilateral third nerve palsy and a contralateral hemiplegia. But much more often, the PCA occlusion is more distal. And so it looks more like this, with mainly just the visual field deficit. All right, so here we can see a posterior cerebral artery stroke. You can see the ischemia all the way around the cerebral peduncle and extending all the way back here to the occipital lobe and undersurface of the temporal lobe. Now, if we have a left PCA stroke, and I'm assuming that the individual is language dominant on the left hemisphere, then we can have Alexia without agraphia. All right, so here we've given the patient a left PCA stroke, and an important thing, how this makes sense, is that the posterior cerebral artery also supplies the posterior portion of the corpus callosum, and that's called the splenium. All right, so if we have a left PCA stroke, the patient has a right homonymous hemianopsia. I didn't include macular sparing here. It turns out we usually don't see macular sparing, even though that's always a board question. All right, so the patient has an intact right occipital lobe, and so they can see everything off to the left side, but you don't read in the occipital lobe. You interpret the words in Wernicke's area. So to be able to read, the patient needs to be able to get this vision across to Wernicke's area. All right, and since that's not possible because the ischemia here has affected the splenium of the corpus callosum, the patient has alexia. They can't read. But it's alexia without agraphia, because if you give the patient an auditory command to write sentences, well, this is all intact, right? Heschel's gyrus and the associated Wernicke's area is intact, and we could all write sentences with our eyes closed without difficulty. And so the patient can write sentences. They understand the command to do that. They can move it forward to the motor cortex to move the arm and hand to write. But then when you ask the patient to read the sentences that they just wrote, well, now that involves vision, and they can't do that. All right, so Alexia without agraphia is then generally something that we will see only with a left PCA stroke. Now, we've already been over the small vessel stroke syndromes, but I just wanted to contrast here that, remember, these small vessel or lacunar stroke syndromes, we tend to have just one isolated deficit. That's it. Hemiplegia, hemisensory loss, hemibolismus, for example. So we don't have all of the large vessel symptoms, which are the ones that we just went over. Aphasia, homonymous hemianopsia, anosognosia, motor and sensory loss together, which again is what we see with an MCA or an ACA stroke. And so they're very different, lacunar stroke syndromes. Now, intracerebral hemorrhages can look a lot like cortical strokes. And so the most common hemorrhage of all is subarachnoid hemorrhage from trauma. But those don't tend to cause focal deficits typically. But the hypertensive hemorrhages here are the ones we're talking about. So these are patients that have a long history of hypertension, which damages the small penetrating blood vessels, like the lenticulostriate. And so they form these little microaneurysms called Charcot-Bouchard aneurysms. And so bleeding is into the brain parenchyma, because it's the penetrating blood vessels that are affected. So one of the clues that can distinguish these from a cortical ischemic stroke is that since we're introducing a new volume into the brain, we have increased intracranial pressure. And so that is going to cause the patient to be very sleepy and confused. Now, most patients I see that have a big middle cerebral artery stroke, they're wide awake, they're alert. But if you have a hemorrhage, now you've got a patient you need to keep tapping on the shoulder to wake them up. Frequently nausea and vomiting from increased intracranial pressure, and these patients will have a headache, unlike most of our patients with ischemic strokes. Okay, but it can be difficult. It's not always easy. So again, here are the lenticulostriate blood vessels, and so what we get here are these little microaneurysms, Charcot-Bouchard aneurysms, which can then rupture and bleed. So the most common location is in the putamen. So here's the internal capsule here on the left and on the right. And so notice that the hemorrhage is lateral to the internal capsule. So here's the putamen out here. And so this will compress the posterior limb of the internal capsule. So patients present with an acute contralateral hemiplegia and hemisensory loss. And the optic radiations are coming right around here, going back to the occipital lobe. And so they often have a contralateral homonymous hemianopsia. So this can look a lot like a middle cerebral artery stroke. But again, look for the signs and symptoms of increased intracranial pressure. Next most common location is the thalamus. Okay, so we're now medial to the posterior limb of the internal capsule. And so since this affects the thalamus early on, the main deficits may be sensory, but in a large bleed like this, we would expect to involve the motor fibers in the posterior limb. So we get a contralateral sensory and motor deficit. And remember, the thalamus sits right on top of the midbrain. And so the midbrain is important for vertical eye movement, so these patients will often have difficulty looking up and down. And so here's the thalamus. Again, that hemorrhage will affect the midbrain and frequently vertical eye movements. Now, the worst prognosis for hypertensive hemorrhages occurs with a pontine hemorrhage, which we can see right here. So these patients often present with abrupt loss of consciousness, and pinpoint pupils are kind of your classic board giveaway here. It's really a bilateral Horner's syndrome. But also these patients may have impaired corneal reflex because cranial nerves 5 and 7 are in the pons, and they may have impaired vestibulo-ocular reflex, like if we're moving the head back and forth or doing cold caloric testing. That can be impaired with a hemorrhage here in the pons. All right, so these patients may present in a coma, and so if you get a vignette, someone rolls into the emergency room in a coma, they have pinpoint pupils, then it's a pontine hemorrhage until proven otherwise. All right, the fourth hypertensive hemorrhage, but probably the most important one to recognize right away, is a cerebellar hemorrhage. So now we have a hemorrhage in the cerebellum, so patients will have ipsilateral ataxia. If the bleed is more midline, it might be more of a truncal ataxia. They'll probably have nystagmus. The mass effect here will cause an occipital headache and often neck stiffness. And anytime we have something acute in the cerebellum, nausea, vomiting, and vertigo are common. And the reason these are so important to recognize is this hematoma can be evacuated quite easily. So these respond well to neurosurgical intervention. So even though I told you MRI looks at the posterior fossa better than a CT, which is true, but in this case we want a CT because CT is very sensitive for hemorrhage. We want to get a quick answer and get the patient to appropriate treatment right away. All right, so here are the different locations here. Cerebellar hemorrhage we talked about. Here's a pontine hemorrhage, obviously not compatible with life. Notice the posterior limb of the internal capsule, the putamen's out laterally here, so there we can see the bleed on the other side. And then a thalamic hemorrhage is more medial, which in this case was a very large one, so it certainly extended out to a significant degree. Now I'll just mention here our watershed strokes, usually from prolonged hypotensive event like a cardiac arrest. And so the watershed areas are between the major cortical blood vessels we just talked about, like between the middle and anterior cerebral artery. And there are other areas of the brain that are susceptible to hypoxemia, like the Summers sector of the hippocampus and the Purkinje cells of the cerebellum. But probably most clinically relevant to remember about hypotensive strokes is that there is also a border zone within the middle cerebral artery, between the more proximal and distal portion of the middle cerebral artery. And if you look at this area here on the homunculus, it's mainly the proximal muscles of the arms and legs. And so patients that have a hypotensive event, usually they're going to be in a coma for a while, but as they wake up, if you are seeing a stroke like this is when we get this person in a barrel or man in a barrel syndrome, where they come out of their coma after their cardiac arrest, and they have pretty good hand and feet strength, but their proximal muscles are weak. That's why it's called man in a barrel syndrome. Okay, we'll just say a little bit about venous drainage of the brain. I'm not going to go through all of this, but if you want to pause the video, you can remind yourself about superior and inferior sagittal sinus and how all of this drains out here into the internal jugular vein here. We've already talked about cavernous sinus thrombosis, so I mainly just want to mention here cerebral venous thrombosis of the superior sagittal artery, which is the most common venous occlusion. And you can see, quite unusual, this occurs in younger women, and it can be related to oral contraceptive use, and most often we see this immediately after delivery. There is a hypercoagulable state after delivery and oftentimes a little dehydration, and so that may lead to occlusion of the superior sagittal sinus. And so we immediately, when you occlude that vein, that arterial pressure and flow can't drain into the venous system, and so you get increased intracranial pressure, everything backs up, and so you get ischemic and hemorrhagic strokes that line up here along the midline. And so these women will complain of a headache because of the increased intracranial pressure. They may have a bilateral sixth nerve palsy. Remember, that's common with increased intracranial pressure. They'll have papilledema from increased intracranial pressure, so they'll have visual loss. And again, like any increased intracranial pressure, we'll have kind of a confused patient. Now, the focal finding they may have on exam, because this is going to be midline, and the leg fibers are midline, they may have focal leg weakness. Okay, and the cortical irritation from these ischemic hemorrhagic lesions may also result in a seizure. So the main thing you'd be primed for this is a woman who's having, the variety, some of these symptoms after delivery. Okay, and so we'd want to pick that up right away. A D-dimer test, which tests for fibrin degradation, is a very good screening test for this, so we'd want to do that. And then we want to do an MR venogram. And here we can see the superior sagittal sinus, which should continue like this all the way across. And so we can see we have an occlusion here. And so these patients are treated with anticoagulation to try to recanalize the venous sinus. Remember how a bilateral sixth-nerve palsy looks. When the patient looks, in this case, to the right eye doesn't abduct. When the patient looks to the left eye doesn't abduct. And so the bilateral sixth-nerve palsy should also always raise concern, if it comes on acutely, of increased intracranial pressure. Now, there are other hemorrhages. And so just as a clue, if you see a cortical hemorrhage like this, well, that's not a hypertensive hemorrhage. So you need to work that up and figure out what is the cause. It could be an arterial venous malformation or something else. But if it's not in a typical, one of those 4 typical locations, you would always need to do angiogram and other studies to figure it out. I'll just mention a couple here. Cerebral amyloid angiopathy is amyloid beta accumulation in blood vessels. And so this often runs in parallel with Alzheimer's disease, but it can be sporadic. And so this usually results in a bunch of asymptomatic, what we call microbleeds, but we can pick that up on MRI imaging, or occasionally there may be a larger cortical hemorrhage. So again, just like Alzheimer's, very uncommon under the age of 65, and remember the APO E2 and E4, the abnormal forms of the apolipoprotein that we talked about in Alzheimer's. If you have those, you're more likely to get not just Alzheimer's and vascular disease, but cerebral amyloid angiopathy. And so when we do an MRI, we can do what's called a gradient echo MRI, and we see all of these little microbleeds. And here are a couple large cortical hemorrhages that a patient with amyloid angiopathy experienced. And then finally, vascular malformations. So remember that AVMs, the vasculature here is not normal. We have abnormal arterial venous connections without a capillary network. Aneurysms form, which can also bleed. And so these tend to leak over time. They tend to present in younger individuals, either with presentation from hemorrhage, or the cortical irritation may result in a seizure. Okay, but if you do a scan, these are usually pretty easy to detect. I won't go into treatment at this time. And then finally, we'll have a separate lecture on head trauma. I just did want to mention, of course, that bleeds from subarachnoid, subdural, and epidural hemorrhage are common. And I'll just mention here that, remember, if we have someone that has like a motor vehicle accident with a lot of bone fractures, that we can get fat emboli. And that usually presents here we can see at autopsy, these little fat emboli with a bunch of subcortical hemorrhages, which we could see here at autopsy.